invitation. Okay.
It's my honor. Thank you.
Thank you.
Will I be the first to speak? Is my lecture?
Yeah. من شروع کنم دیگه رو جمله. Dear colleagues, welcome to update on age-related macular degeneration. It's my great pleasure to introduce a panel of international experts with huge experience in managing this important condition. Resul from Resul Hospital and Professor Hegman from University of Utah and Hamid Riazi from Tehran University of Medical Sciences. Also, I would like to thank Dr. Hessam Hashemian for preparing this webinar. I suggest we hear presentation first and follow these with a discussion with the panel. Without further delay, I would like to invite Professor Resul to give his presentation for delivery system for neovascular AM. Dr. Resul is Director of Retina Service of Resul Hospital and Professor of Ophthalmology at Thomas Jefferson University in Philadelphia. He is the founder and former director of Wills Eye Clinical Retina Research Unit and former chairman of the American Academy of Ophthalmology Retina Basic and Clinical Science course. He has authored over 200 publications, along with over 50 book chapters and 9 major books. He has been an investigator in numerous major clinical trials, developing new treatment for retinal disorders such as macular degeneration and diabetic retinopathy. Dr. Resul, please. Dr. Resul, are you ready?
I am ready, and thank you.
Okay,
and thank you.
We are waiting for your speech.
Thank you again. It's a great honor to be invited to speak to you here today. I will now share my screen, and I'm hoping you will now see my slides. Is that correct?
Yes.
Thank you. And here we go. Again, it's a great pleasure to talk to you here today to give you the very latest port delivery system being utilized for neovascular AMD. Here are my financial discussion. A lot of this relates to clinical trials that have products in development or recently approved for wet treatment. As many of you are aware, port delivery system is a sustained delivery device. It's a intraocular scleral-based reservoir drug delivery system. It's in the OR, into the eye, and refilled in the office with a special refill change needle. So it's a one-time to the operating room to insert the device, initially filled a high concentration customization of ranibizumab, and that slowly releases drug by passive diffusion into the cavity. This was recently FDA just under one year ago in the United States for the treatment of neovascular AMD in patients that had some previous VEGF injections. This is a device meant to be utilized in what we call the main phase of wet AMD management. Injections have brought the disease under control after the induction phase, as it's called. It's a small device. It's about 2.5 millimeters in its width, as shown here in the picture. Sitting on the sclera, the septum with a soft silicone cone diaphragm. That diaphragm is only a millimeter in diameter. That's what's penetrated the needle during the refill exchange. That septums or the phalange sits outside top of the sclera to support the device, and this is the conjunctiva. Show a brief video of the basic operative procedure. This is actually a case of mine from the TUMS study. We insert an infusion cannula just to pressurize the eye, but it's left off for most of the surgery. A 6 by 6 millimeter conjunctival tenon opening is created supratemporally. The sclera is photodilated, and then the device is being filled initially concentration version of ranibizumab. Millimeters back in 3.5 meters in length. We do a full thickness cut down with this MVR blade. We measure to make sure it's precisely, and that's 3.5 millimeters. We then regulate the underlying uveal tissue to prevent bleeding, and then we enter his cavity with a 3.2 millimeter, and then the device with this handle is inserted like this, fitting securely and snugly into the sclera. No suture to hold the device in place, and then it sits like that. And then we end the operation by closing conjunctiva securely over the device. There is no vitrectomy. There is no in-torque. Again, that infusion cannula is just to rise the eye as needed during the operation. This is how a typical case would look, and this is a case from one of the clinical trials. The device sitting under the conjunctiva in the supratemporal quadrant. It is not in primary gaze, even with a dilated pupil, even though that is relatively long and begins at the pars plana. The device is then refilled in the office. Special refill exchange needle, replacing the contents of the device with fresh drug. The device only holds 20 microliters, flushing it with 100 microliters to make sure the exchange with new high concentration drug. A phase 2 ladder study, the proof of principle that the device actually formed well to deliver bizumab in an effective concentration that it was both effective and safe. The latter phase 2 study also told us about the ability of the device itself as a sustained platform. The study was successful in that it showed high concentration device utilized in the trial performed as gold standard monthly intravitreal inject control arm in terms of maintaining gains and controlling exudate seen here with the OCT. You can see there's no difference over a mean of about 2 months over the course of the study. The concentration PDS arm, and that's an implant that again inserted in the OR, and then this is refilled as needed, that was compared to intravitreal injections as the control group. And what we saw in this study, because the primary endpoint was the time to the first refill of the device, it was that 100 milligram per ml high concentration arm that performed best. The median to refill was about 16 months, and percent of patients in that arm went 6 or more months without running the refill. So that gave us confidence that the device was releasing at therapeutic levels 6 months in the vast majority of patients. This successful phase 2 study, of course, served as the background for designing the phase 3 trial. The phase 2 study, these were the deleted adverse events, also adverse events of special interest. They're unique to the device, the delivery of the surgery. Vitreous hemorrhage and hyphema by %, overlying conjunctival retraction 4.5%, retinal attenuation 2%, and endophthalmitis approximately 1.7% over the course of nearly 2 years. And that's with 109 devices implanted in the phase. The phase 3 Archway study was then launched and conducted. It assessed the efficacy and safety of port delivery system. Similar patient population previously treated with injections, and randomized 1-to-1 with concentration port delivery system surgery device compared to monthly individual injections as the control arm. And in this study, we refilled the device in the office every 6 months. It was not as needed, and got refilled in the device arm months for this 2-year study with a primary endpoint of approximately only 1 year. The study was successful in meeting its primary endpoint, being non-inferior to monthly injection with the mean change in BCVA baseline. Again, being previously treated, we don't expect vision improvement. We expect vision maintenance, and that's saw. It was identical, both here and actually equivalent to monthly injections in terms not only BCVA, but exudal as measured anatomically by T central point thickness. Now we have the final 2-year results, 96. You can see the best corrected visual acuity outcomes. The port compared to monthly injections were identical over the course of 96 weeks. And this is over the course of 4 refill exchange cycles over that time frame in the study arm. These are patients. So we see good main the initial visual gains. On average, these patients had 5 treatments before they were enrolled in the study, got the device. We also saw excellent exudative control. You can see there's no difference between the OCT point thickness over the course of the entire 2 years compared to monthly intravitreal injection, gold standard control for wet AMD. And in the course of this trial, there was the option to do intravitreal supplemental rescue injections in the device arm 1 or 2 months for each refill exchange. So before every month refill exchange, patients could be supplemented with injections. The good news is that the device so well that very few people needed any supplementation in the port delivery system. 5% or less patients at each refill exchange needed any supplemental injection. Further, in the Archway phase 3 studied a PK analysis looking at both serum and aqueous levels of drug compared to monthly injections, and we can see that before each change, the level of drug in the eye was higher than the trough of a monthly intravitreal injection. And the levels we're seeing in the eye equate to about the level you'd expect about 3 weeks after standard dose of intravitreal ranibizumab. So we're getting drug concentrations delivered in a sustained release fashion, or well above the therapeutic level of disease. And it's conducted for patients in the Arch study. Now, these are patients that had previous injections, so it was like to get injections, and over 80%, 93% preferred the port delivery system device because it was more comfortable and allowed for less injections. In the phase 3 Archway study, the adverse profile related to the device was actually very similar to the phase 2 study. We didn't do surgical modifications going from phase 2 to phase 3, so it was essentially the identical procedure. And we could see very similar rates of conjunctival erosion and retraction, which are potentially serious because it's a setup for infection. And the infection rate came out at 1.6 per device versus 0.6% for monthly injections, and this is over the course of 2 years. So it's the per patient rates of endophthalmitis in patients. For a little deeper dive into the complications for the retina specialists in the audience and those that might be interested ultimately performing this procedure, it's important to know the issues associated with the device. Of course, it's a for patients, less burden, better disease control with the device, but higher complication. There were these reports of conjunctival blebs, and weren't really leaks. What they was just thickening over conjunctiva, and that was very rarely. Conjunctival erosion is a potential significant issue. If the device is exposed, it needs to be repaired promptly, and these patients did have surgery to replace. If it's not repaired, there's an increased risk in endophthalmitis. And conjunctival retraction is thought to be related to surgical technique and closure, whereas conjunctival erosion may or may not be something we can control even with good surgical technique. With endophthalmitis, there were 4 cases of endophthalmitis on 1 in the monthly injection arm. 3 of the 4 cases of endophthalmitis in the delivery in the port system arm was related to conjunctival retraction and device exposure. 3 of the 4 patients did well. One patient, actually, in hindsight, it was probably not infectious endophthalmitis inflammation that recurred in both eyes. But nonetheless, because there's a high rate of endophthalmitis associated with having device in the course of therapy, the FDA, when it approved it, did have a box for the device, noting a 3-fold higher rate of endophthalmitis. Lastly, there's unique implant dislocation. This occurred later in the study because associated with the refill exchange procedure, and these dislocation events were correlated to a surgical incision that was greater than specified per pro. An incision that's too large is a setup for or risk for having the device implant dislocate eye. Serious problem. These were repaired, best avoided with good surgical technique. There is a retinal attachment, both of which were successful in the course of the study, utilizing standard vitrectomy techniques. Concluding, I'd like to share some of the long extension study data. So patients that were enrolled in both the phase 2 ladder study and the phase 3 Archway study, the option to continue to have the device in the eye or get the device if they were in the control injection arm, and get the device refilled every 6 months. Further observation and over the course of another several years. So with this extension study, we now have a long-term, and as of a year ago at the latest data cut, we have over 500 patients having the device in their eye, followed over the course of 4 years. And here are the results. We see excellent disease control with maintenance of acuity at a good level, 40 from the very beginning of enrollment in the phase ladder study. 4 years later, still with visual acuity 20/40 device from the beginning, what crossed over initially from injections to having device 2 years in the portal extension study, and also see excellent control of exudation, slightly better over time, with a lower value here, point thickness again over. So excellent disease control over 4 years using this device, and continues to perform well with very few patient supplemental injections over the course of those 4 years. Also pleased to say that the complication rate for 4 years has not been going up. If any, most of the adverse events are in the first year or two. There are exceptions to that, but like hemorrhage and some issues associated with conjunctiva occurring mainly in the first 2, with very few events later on of the study. One additional issue that came up just recently is the septum, the soft silicone that needs to be penetrated with the fill the device in the office. There have been some cases of implant septum dislodgement, and gets dislodged into the device. It renders the device questionable in terms of its ability form. And if this was to happen, there needs to be exchanged and in fact have surgery. This was actually traced back to a specific lot of device used in the phase 3 study were found to be at increased risk for this dislodgement. But this problem has since been fixed. So with the port delivery system, it's a unique device and unique surgical procedure. A step, although relatively straightforward, they are unique in many ways, and they have to be done with great precision, because even every one of these steps have been correlated with a specific type of adverse. For example, making the large setup for implant dislocation, closure of conjunctiva and tenons is for conjunctival retraction and possibly the erosion. So doing these just right is very important. Since this has been FDA approved in the United States, there's been an extensive training program for retina specialists willing to use the device. It's also associated with specific unique equipment, insert, and then to refill the device. And that's all part of the training program that's now in this. Test of the device in phase 3, the Archway study. We now have the portal study, as I mentioned, seeking long-term. We also now have port delivery system for wet AMD globally in the Velodrome phase 3B study, which is now recruited away in many countries worldwide. This is also being used in the setting of diabetic macular edema, treat DME, and also to treat diabetic retinopathy without DME. That's the pagoda implantes. These are currently recruited in the United States. To date, this figure says over 1,200 PDS surgeries to date. I think actually well over 1,500. Future of neovascular AMD is very bright. We have short-acting anti-VEGF biologics that we're using for about 16 years now in practice that work very well in the AMD. But because of their limited durability in the real world, we offer vision loss over time. We hope we can improve on that in the real world with the new development of more long-lasting biologics, and this includes the recently FDA approved Resul as an anti-VEGF angiopoietin 2 therapeutic, and some recent results with high-dose Septum also looking promising for durability. But with longer durability biologics, we're talking 3, maybe 4 months in many patients, but for sustained delivery and as a therapeutic effect for at least 6 months or so, we now have the FDA approved port delivery system. And in conjunction with that, as we get into really long-acting therapy, we see in the future the for home OCT monitoring that will help us guide how to manage these patients with these longer-acting approaches. Very much.
Thank you, Professor Regillo, for your nice and informative presentation. Professor, I have a question.
Yeah.
Between these new drugs, such as faricimab or hydrogen delivery implant platform and other new drugs, which one do you prefer and which is more acceptable for you use in your routine clinic?
Yeah, I think most wet AMD managed continue to be managed intravitreal injections, and I have started to use some of the newer anti-VEGFs, including Resul, which has been FDA approved and available about 6 months in the United States, and I am seeing better drawing and a bit better durability. It's easily a more durable drug. I think the field in general, both in the States and outside, will shift away from the first generation anti-VEGFs, such as the MAB and aflibercept, to more durable intervals, and that's going to be for most of our patients. The port delivery, because of its higher adverse event profile, is not for everybody. In fact, it's going to represent a small proportion of our patients. I've done a lot of these surgeries in the course of the clinical trials, and I've had a very good experience with it. But the reality is, most patients, because they do well, getting injections 2 or 3 months are not as inclined to go to the OR to have the device. And the patients that might more amenable and to want the port delivery system, patients that are getting very frequent injections, 4 or 5 weeks, and those are the patients I'm now starting to utilize the device in. But that's going to represent probably more than 5, 8 of my patients that will probably end up in the device in their eye. We do have good injected drugs in the office, and getting even better ones that will give us 3 months, even 4 months of durability.
Dr. Riazi, do you have any question?
Thank you very much, Dr. Resul, for your nice presentation. Also, I have a question. Do you think that in future can we use other anti-VEGFs like aflibercept with this system, or is there any plan to test other medications like aflibercept with these systems?
That's an excellent question. I get that question all the time. So this device is designed, the internal aspect of the port delivery system has titanium called a release control element. And basically it's the metal with pores, and those pores, the sizes of the pores are specifically designed for the ranibizumab antibody. So that's about 47 to 50 kilodaltons. If you try to put a larger biologic molecule in the device, it will through the pores as easily affect the diffusion characteristics. And in fact, you probably can't concentrate a larger molecule well enough within this port because it only holds 20 microliters. So the simple answer to the question is no biologic, because they're all large, they're 100, 120, or even 150 kilodaltons, will not work on the device. However, the maker of the device, Genentech, is testing a unique bispecific antibody fragment. This is not that's commercially available, but it's made into a fragment about ranibizumab, and that's being tested phase 1 in this device. So for faricimab, the bispecific anti-VEGF Ang2 molecule, and cutting it down into an antibody fragment and put a device phase 1 early testing.
Thank you very much. But I think the best result of the system is that over 90% of this system, this patient who received port delivery system did not receive supplemental treatment before each refill exchange procedure. This is, I think, the best thing that we can use these devices.
Absolutely. There's no doubt about it. The device, I think, exceeds expectations with regards to disease control, reliable disease control. I'm going to say for all comer patients. It's true that patients that require very frequent injections it may not be as durable for those patients, but across the board, it's very, very durable, right? It gives almost everyone at least 6. I think the best is the concept of the device is the proof of principle that same delivery is not only well tolerated, but it is probably the best way to control the disease of monthly injections. The downside is the complications associated with it. If we can reduce that, I think that would make for greater acceptance. But I know in the United States, there have not been a lot of devices implanted there. A lot of doctors are still holding back a little bit until they see longer follow-up. The longer follow-up data is promising. They just now need to get trained and understand all issues associated with using, implanting, and refilling the device.
Okay, thank you very much, Dr. Resul, for your nice.
Thank you.
I suppose, Dr. Resul, if you have time, we want to share with you some case presentations, and is it possible for you to stay with us?
Sure, I'd be happy to see cases and talk them.
Thank you. Okay, do you see the cases?
I do.
Yes.
Case one.
Yes, case one.
Case one.
Dr. Riazi, please.
Our first case is about a 60-year-old man with best-corrected visual acuity of 20/20 and no history of any treatment. So as you can see in this FA, we can see some staining as well as leakage in the inferior part of ova. OCTA shows the vascular network, and also we can see a shallow regular pit with subretinal fluid in the OCT. I would like to ask you, what is your approach for this case?
I'm glad you caught the wet AMD very early. And we're dealing with a small lesion with a little bit of fluid and excellent vision. The patient has an excellent prognosis treatment. There's no doubt about it. Active neovascular AMD needs treatment. I would start with anti-VEGF agent monthly. The fluid is gone. I'm sure that will take only a couple of injections or so. The treat and extend mode, so slowly spread the distance out over time. Typically, I'll start with ranibizumab or aflibercept, and tried and true agent in our hands for a while. I'm glad you have GEA, and that definitely shows neovascularization and even obvious leakage on the fluorescein angiogram. I would start anti-VEGF therapy, even with this good vision, to try to get disease stabilized out.
Okay.
Thank you very much. And do you prefer to do to inject based on treat and extend strategy from the start? For example, after 1 or 2 injections, if the subretinal fluid resolve, can we start treat and extend, or you prefer to do 3 or 4 loading doses and then start the treat and extend extension based on the 3 loading dose responses?
Yeah, I don't necessarily do a minimum of 30 injections. If that looks perfect after 1 or 2 injections, we'll start to extend. Of course, we're only extending by 2-week intervals, so we're kind of blending the induction and the maze, and it's a slow progression, if you mean, in terms of treatment. So it's not that we're doing 2 or 3 injections and watching, which would be like, but and not all patients need 3 injections. Since some will need more, of course, monthly injections to get the macula dry, but 3 just happens to be the average or mean number of treatments needed to the macula in the majority of wet AMD cases. So I will start to extend even if it looks good after 1 or 2 injections.
Okay, thank you. And Dr. Resul, if we have the intraretinal fluid instead of subretinal fluid, can we do treat and extend from start instead of the 3 loading doses?
Yeah, I think we can, as long as you see good resolution of fluids. That's ideal. People think it's best to aim for dry macula, especially the intraretinal, as you alluded to, is usually more and carries a prognosis. Subretinal fluid we may not be able to completely get rid of, but that may not be necessarily a bad. Small amounts of non-fluctuating subretinal fluid can be well tolerated, and the Harvard group analysis did show that intraretinal fluid is almost always a marker of poor prognosis. Subretinal fluid may or may not. I think it's a good goal to have, to dry the macula and keep it dry. And so unable to dry the macula, at least keep it as possible and minimize the fluctuations or the recurrences, because I think it's harmful. And in fact, there's from Usha Chakravarti, looking at Ivan and Kat, that it's just the presence or absence of fluid, how much it fluctuates and how often it fluctuates. The cumulative exudative burden is a good way to put it.
Dr. Riazi.
Okay, our second case is about a 63-year-old man with metamorphosia in his right eye, and vision is 20/25, and he has no history of any treatment. And you can see in OCT, we have no obvious intraretinal, subretinal fluid except a very small part in the lower OCT scan, and in the OCTA we can see a vascular network. I want to ask Dr. Resul that what is your plan for this patient? Is it actually a non-exudative macular neovascularization?
This is a very interesting case. I'm impressed you're catching your wet AMD so early. We get our best outcomes when you catch wet AMD early. We once published a paper that if you catch wet AMD when the acuity is 20/40 or better, I'm talking truly wet AMD, exuding, you can keep the patient 20/40 or better over 85% of the time. It's over 2 years or so. Here's patient 20/25. The patient has, and that might influence what I do here. If this patient symptomatic was 20/20, I would not treat non-exuding CNV. Incidental C that's truly we'll call occult. But I like the word you used, non-exuding. I would watch those carefully because the vast majority will eventually exude, and then we can start the treatment. However, I have to say in this case, we are seeing a sliver of fluid. The patient is symptomatic. The visual acuity is not quite perfect. I might consider starting treatment in this patient. I'd be faulted with waiting another month. So I don't think anything bad's going to happen if you wait. And I would guess that many of our colleagues might wait and others start treatment. I might be inclined to start the treatment. I'm glad you have this OCTA, because if I was to look at that OCTA, I would be unsure whether it's even wet. But the OCTA definitively shows new blood vessels, and with a little fluid and symptoms, kind of tips the balance in favor of starting treatment. Did you treat? I think you're muted.
So thank you very much. Is the shape of the neovascular network in OCT angiography, like the tortuosity, density, and something like this, is it important for you or not to decide any treatment for the patient?
The question is it important to have CTA or to come again with that question?
Is the shape of the network in OCT angiography, is it important for you to decide for treatment, or just you decide based on the OCT and the feature of the OCT scan?
So nowadays, I find not doing much fluorescein angiography anymore. Most cases are also, as you know, when you do a simple OCT, and you don't need anything more than that. These signs of exudation, some blood, maybe fluid, and you see it on OCT. I start treatment without any other testing. However, for questionable such as this, I think OCTA is a very good test for this type. Or if you don't have access to it, a standard fluorescein angiogram can also be helpful. The reality is that, at least in the United States, specialists utilize many off locations, and not all of them have OCTA. CTA is a very useful. I have it, I use it, but I don't utilize it regularly. Don't have access to it in all my offices. Yeah. So here we're fortunate. we did this test that definitively says we got wet AMD here.
Dr. Resul, how do you monitor these patients? How do you monitor the patient with non-exudative CMV?
So most of the time, I would be watching it.
OCT, or self-monitoring, or other.
Oh no, I would bring this patient back frequently and do OCs and see signs of leakage or wetness. Look for signs of fluid. But once I start to see fluid, I will definitely treat. If there's no symptoms and no fluid, I probably not treat.
No. Thank you.
And what is the interval for follow-up for this patient for you?
So if I did not treat him and coming back in 4 to 6 weeks, and unfortunately, I probably have to continue to watch them that closely. I wouldn't let them go very long because that could start up and start leaking any.
Okay, thank you. The next case is about persistent subretinal fluid. A patient, a woman, 64 years old woman with a history of 6 intravitreal bevacizumab injection, monthly bevacizumab injection. But as you can see, the vision is 20/40, and we have a packet of subretinal fluid by 6 monthly treatments. So what is your next step for this patient?
Yeah, this to me looks like a people would call a sub-op. Now, if the vision was 20/20 or 25, we might tolerate that, and even start to extend our treatments. But I'm concerned that this is not this patient can be or should be. You definitely have wet AMD, so it's not a masquerade. And with no change in persistent fluid after 6 monthly, I would consider switching to either ranibizumab or aflibercept, or now even faricimab. There is evidence to suggest aflibercept and now mab might be better drying agents than bevacizumab. I know they work better in the setting of DME, not necessarily wet AMD. With the persistent fluid, I think it's worth considering to see if you can get better resolution of the fluid and better gains. So I would consider a switch. And if the switch did not show me any change, it would just look. It doesn't look like this is polypoidal disease, but if it was, some would consider adding in PD. At this stage, with this level of vision, based on the OETA, I think you're dealing with standard neovascular AMD, and probably the best thing to try to switch the treatment to one of the other anti-VEGFs.
Thank you very much. And should there be zero tolerance to fluid in the retinal environment in neovascular AMD, or actually we can tolerate some persistent SRF? As we know, the fluctuation of the SRF is not a good prognostic factor, and actually it is a bad prognostic factor for visual acuity and also fibrosis. So we prefer to treat these patients. But if we have a non-fluctuating SRF and persistent SRF despite many treatment, do you prefer to eradicate the SRF, or in this situation just follow the patient with observation?
Good point. We know fluctuating fluid would not be good, and does tend to lead us to a worse outcome. So it's nice to distinguish fluctuating fluid. Is a small amount of non-fluctuating fluid. I will sometimes tolerate that, and sometimes I don't have a choice to get rid of it, regardless of what you do. You're right. There have been studies that indicate that sometimes these eyes are less likely to develop atrophy. Some even say they think it's a protective act. I'm not so sure that's the. It might be just a marker. Eyes are less likely to develop that, but nonetheless, I wanted to switch if I saw it dry up, I think in the long patients are still better off. The agent and saw the persistent fluid, I would try to maintain the status quo and hope that they don't vision loss over time. So it's a tough question to answer. We don't know all these to that particular this particular situation.
Thank you very much. And Dr. Farid, do you have any questions?
No,
Okay.
thank you.
And the other case is about 40 years old female with vision 20/20 when perfect reading performance. The patient is on treatment extend protocol for every 3 months injection, and the patient has been treated about for 3 years. Do you prefer to stop injection for this patient or not? As we know that in the real world studies, the patient that have at least 1 injection per year also have a better visual outcome after about 10 years, in contrast to patients that have no injection after the resolution of the SRF. Do you agree with this or not?
Well, let's just start by saying this is a wonderful. You can't then 20/20 every 3 months. Now, the problem is there have been studies, and in fact, some people use the term treat, extend, and then stop. And I used to actually many years ago, if I could get a patient, it's great, and extend to 3 months, our original anti-agents, I used to try stopping. But the literature and my own experience has shown that for these patients, ultimately, eventually they will recur, and some of the recurrences can be pretty bad. And therefore, I don't want to risk setbacks. I tend to continue treatment, and I would continue to treat once every 3 months. Because even though it's true, some patients can go indefinitely and do fine in stage right without further. That was seen as long pronto. It was seen in the Harbor study that not all patients always need ongoing treatment. The problem is that's a minority of patients, and we can't predict who those patients are. So I think it's too risky. Many of the studies show that if you stop over 50% will eventually start to leak again. And so if a patient's only coming in every month and you stop the treatment, they could have a considerable setback. They may not recognize in between visits. So I prefer I prefer to continue the treatment and not stop for the vast majority of my wet AMD treatment, wet AMD patients.
Okay.
And the next case is about the PCB. Unfortunately, we haven't any access to vetroprofil now in our countries. So it's a problem for us for these cases, and also other cases with pachychoroid spectrum. So this is a 47-year-old woman with history of multiple IV injections with the PCB 20/80. Actually, based on these OCTs, is it necessary to do FA or CGA or not? And also, what is your next plan for this patient? The patient has a history of multiple intravitreal bevacizumab injection, despite no treatment response.
Well, this is certainly an atypical situation, and the first red flag is how young this patient is. So that should alert you to the possibility that you might not be dealing with AMD. So in my differential, this is either central serous chorioretinopathy or presenting in a patient, somewhat atypical in that fashion. So in a typical situation, just saw that OCT, I wouldn't know for sure, and especially knowing that they didn't respond to any of the multiple injections of an anti-VEGF, I'm beginning to think this is either masquerade or maybe it's suboptimal response. Something's right, and I think both and I should say an FA is certainly helpful. And your F here shows leakage, although to me it almost central serous like, and I think even better for this patient, ICG would definitely be useful, but probably the most useful test would be an OCTA, because if I didn't see any abnormal blood vessels, they're dealing with central serous. So when you're central serous versus wet AMD, OCTA is very useful, most useful scenarios for that test. ICG would certainly be useful in looking for polypoidal lesions. It could be a macular variant, a standard peripapillary. But I'd be curious to see what ICG and or OCTA show patient, and then about the next steps. Should we switch anti-VEGF? Should we add PDT? And in fact, if you add PDT step without knowing whether it's PCV or central serous, of course, the PDT will be great for central serous. So you lose, but you'll want to know if you need to use the anti-VEGFs or not.
Thank you. Dr. Parag, do you have any question? The next case is about 67 years old man with recent visual loss in his right eye. You can see the baseline OCT, and after 3 monthly and 3 bi-monthly intravitreal aflibercept injections, the subretinal fluid is resolved and the red light is also reduced. But after about 1 year, after 1 year at the first injection, we can see a recurrence of subretinal fluid in OCT, and the vision was dropped. What is your next plan for this patient after the recurrence? The patient bi-monthly intravitreal aflibercept injection. You prefer to inject monthly again, or reduce the injection every 6 weeks and then every 4 weeks?
Yeah, I would definitely reduce the treatment and back down at least for a while, 6 or even 4 weeks. If it's a smaller 6 weeks, it's a big recurrence, maybe back down to 4 weeks. Maybe you could consider the drug to something that might be more, such as in our hands for faricimab now, and maybe we can re-extend back or longer and keep the good control. But I think you're forced to get aggressive, act a little bit. I wouldn't tolerate this amount. I would not keep the patient on the same 8-week interval with the same bug.
Yeah, thank you. And the final case is about a 64 years old woman. You can see the OCT of both eyes here. The vision of the right eye is 20/32, and the left eye is 20/100. In OCTA, we didn't see any vascular network, but in the right eye we can see rosenoid head, and in the left eye we can see a head with subretinal fluid and exudation. So the patient was treated with 3 monthly intravitreal aflibercept injections, and the subretinal fluid was reduced. And after about 6 intravitreal aflibercept injections, subretinal fluid was reduced more, and after 8 injections, the SRF was resolved and the PET height was also reduced. But in the right eye, the patient had reduced vision, and as you can see, the PET was enlarged. So what is your next approach to this patient? Is the enlargement of PET with visual loss, is it important for you or not?
Concerned, because the left eye started out with a large ED and a very similar appearance. I'm concerned that the right eye might be. I'm not certain of that yet. I'd like to see an OCTA, and if I saw neovascular, I would start the same medicine. You got a great result in the left eye. I would use the medicine in the right eye. if I didn't see blood vessels on the OCTA, I want to just watch, because we've all seen cases where we get these enlarged drusenoid PEs without neovascularization that will rise. But if there's been a drop in vision and OCTA shows new blood vessels, definitely start the treatment in the right eye too.
Actually, we didn't see any neovascular network in the baseline of the left eye also. That and just
I noticed that.
Yeah.
It's funny. You had a wonderful result in the eye, and yet I also noticed that ETA didn't show definitive blood there either. It kind of looked again almost vitelliform like, but nonetheless, the proof is in the pudding, as they say, right? With regards to starting a treatment and seeing an improvement. So you can't be wrong just watching that right eye, even with the enlarged PED. But because of the course of the left eye, that's definitely influencing the way I'm thinking about the right eye.
Okay, thank you very much, Dr. Resul, for your experience and nice talk with you. Thank you.
These are wonderful cases, by the way. They show all the nuance. It's people easy just to start injecting, let the fluid go away. These are all sorts of variants on that what we see in real work.
Thank you very much.
Dr. Resul, thank you very much. I would like to thank you, our panel, for sharing their work with us. I have personally found this session extremely informative and interesting. Many thanks for your participation, and I also would like to express my gratitude to all of you in the audience for your support. Thank you very much. See you later.
Thank you. It's been my honor. Thank you for having me, and I'll sign off now.
Thank you.
Bye-bye.
Nice to meet you. Thank you, Dr.
Bye.
Bye-bye.